blossoming pneumonia. So this will come back to in a few minutes on the undisclosed medical conditions. And post-op complications were common in this group. It's a really sick group: renal failure, pneumonias, strokes, and so forth. And then when we looked at, we specifically wanted to know, was there anything that identified who was going to survive in this transfer, so we could begin to either identify and select patients better, but predominantly to look at if there was any modifiable factors that would enhance outcome. And you see highlighted in red some of the findings. If you had a complex procedure, and a complex was defined as anything more than a first-time coronary bypass grafting, significant reduction in survival. If you had just a simple bypass, there was a likelihood you were going to come back, and this sort of makes sense. Probably just moderate stunning of the ventricle that's going to come back. The non-survivors had more complex procedure, but it brings up the question that Mike has asked recently: is could we have improved recovery if we had prolonged the survival, if we had a device that we could support them a little longer? And then these undisclosed conditions on the bottom that seem to be indicative of poor outcomes were the presence of multisystem organ failure and a stroke. If you were free of these other adverse conditions, you'd tend to do pretty well, and that's pretty obvious. The type of support you were on, and these are small numbers, so you can't make much of them, didn't seem to make a difference. And again, I don't want to use this as a selection criteria for transfer acceptance, but more of an idea of who's going to do well. Now, there's been a large series of ECMO patients out of Germany. Our ECMO experience supports the complexity of the procedure. The more complex it is, the less likely you are to survive any type of mechanical support. And then we were looking at the data. That's why there's a question mark there. The Gonzo emailed me the p-value is significant. It's less than 0.01. But if you can convert to a long-term survive and you can bridge it to transplant, which makes sense, you're more likely to be a survivor than if you can't be. So that's sort of a no-brainer. But the complications that were present didn't seem to make a difference. And let's see, the slide seems to have been moved. This is my final slide, is that the expertise and efficient utilization of resources is part of the idea behind the hub and spoke concept. To really improve this, it requires education and communication between the hub and the spoke team. How do you set the patient up? How do you manage the patient? And I think some of the speakers that will follow will start to talk about the initial management, which I think is critical, and the need to reduce the complications prior to transfer, because the presence of those complications what are impacting outcome. We're going to try and look at, both in our series and then with some of the Abiomed database, that if there are deaths that are on support, either because we withdrew or that we weaned and then died, if there's ways to modify that, prolonged support, something like the ventricle. And at this point, I still think that in these critically ill patients, a salvage or bailout destination therapy as yet is not an option, and I really firmly believe that. So that's my talk, and I think that I just want to make sure I sequence next. Mark Anderson is next in line, right? Do I have the